Yeah, live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Amogs Website and Publications Committee. It's my privilege to introduce the convener of today's webinar, Dr. Rashmi Kahar, ma'am. Ma'am is the President of Obstetrics and Gynecology Society of Amravati, Chairperson of High Risk Pregnancy Committee, Amogs. I welcome you, ma'am, and I hand over the session for further proceedings.
Thank you very much, Shield Healthcare. On behalf of the organizing team, Amogs Website Committee, Amogs High Risk Pregnancy Committee, I extend a very warm welcome and a heartfelt welcome to all the dignitaries today and the viewers of this webinar. This is the second webinar of the series of maternal-fetal medicine we are conducting under the banner of Amogs. And the program has been very well crafted and designed by our respected conveners, Dr. Radha Lakshmi Madam and Dr. Sujit Konkar. Dr. Sujit Konkar is about to join. He is the chairperson of Amogs website committee and a former chairperson of fetal medicine committee of Amogs. He's a maternal-fetal medicine specialist and he's about to join. And another convener is our respected Dr. Radha Lakshmi Madam. I would like to introduce Madam to the House. Dr. Radha Lakshmi Madam is Secretary of Kurnool Society and she is Professor in OBGY Department at Shantiram Medical College, Nandiyal. She is holding a very key position in several professional organizations and mainly she is at present Honorary Secretary of both the districts, the Kurnool and Nandiyal. She is the Zonal CME Coordinator of Zone 6 of Andhra Pradesh OBGY Society. And recently, she is a recipient of Best Doctor Award in Kurnool in 2017 with many publications and paper research articles to her credit. I welcome you, Madam, and we would like to hear from you on this occasion. Over to you, Radha, Madam. Please unmute, Madam.
It is my privilege to convene this program along with Dr. Sujit. Sujit is one of my good old friend, and I came to contact with Rashmika Kahar in the recent past, and I am very blessed to introduce Rajendra Singh Padesi sir and Kiran Kutkoti sir and Bharti Maheshwari madam to this program. So, Kiran Kutkoti sir is the President of Amogs. He's the ex-vice chairperson MTP Committee Foxy 2009 and 11, ex-chairperson MTP Committee Amogs 2012.
Dr. Radha, it's okay. Dr. Radha ji, it's okay. Thank you. It's okay.
Thank you, sir.
Yeah.
Now I request the CVF Rajendra sir. Sahiti.
Sir is immediate past president of Amogs, and he is the mentor, guide, and supporter to most of the Amogsians, and not only Amogsians, also the Foxy members.
Can you see the CV slide, ma'am?
Yeah. Sir presented 21 national and international papers, 7 times best paper awardee in Foxy and AICOG conferences. Is faculty in AOCOG 2011.
It's okay, Radha. It's okay. You can
Thank
skip
you, sir.
that. Thank
you. Radha Madam, would you like to say something on this webinar?
So I request Kiran sir to tell few words about the Amogs regarding this webinar, sir.
Yes. Thank you. At the outset, thank you for inviting me as the chief guest for this particular webinar. And I would like to put on records and welcome Dr. Kanchan Sharma and my close friend again, Dr. Bharti Maheshwari as the guest of honors for this program. Big thanks to Kurnool Society also, as well as to Vizag Society also for joining. And it's really a pleasure. Although it's a website committee program, I know that both Sujit is one of the fetal medicine consultants and specialists and former chairperson of the fetal medicine committee and now gunning for the fetal medicine post chairperson in Foxy, and I would request all of you to take up this cause of Amogs to everyone. And of course, the other co-convener Rashmi. Rashmi is also one of the contenders for the chairpersons of the high-risk pregnancy committee. And my best wishes to Dr. Radha Lakshmi also, who is the convener, and also Dr. Radha, we would also like you to be in some kind of position, whichever you wish in the years to come. Okay, because
Thank you, sir.
it is okay to ask for votes, but again, Amogs is also going to come forward and help you wherever and whichever position that you wish to go ahead. So thank you so much. Thank you so much. And today's two topics again by Dr. Jagruti, first trimester, and by Dr. Manikandan, again, very good speakers on the second trimester genetic sonograms are very good. And I mean, we would love to hear from all of you and all the speakers and the chairpersons also for their opinions. And really, Sujit, you are doing a very good job along with Rashmi. And thank you so much for inviting me as the chief guest. And I look forward for all the Amogsians as well as the Foxians to get associated with Amogs, because Amogs is such a large body. It would not be inappropriate to say that 25% of Foxy comprises of Amogs, more than 25%. Okay, so it's a large landmass and a base. And we are doing good things, and Amogs is always inclusive. There is always a saying that Amogsian should be inclusive. So we are definitely inclusive, and we would definitely include you as a faculty members in all the webinars also. In case any one of you wishes to be faculty members at any of the Amogs conferences or Amogs webinars, I would appeal to all the current chairpersons also to incorporate as many as non-Amogsians, that is other societies. So there is a big cohesiveness and camaraderie amongst everyone and with Amogs. So thank you so much for involving me as the Amogs president. And I would also like to acknowledge Dr. Pardeshi sir, because he has taken Amogs to a different level. And I would definitely like to strive and increase the connectivity of amongst Amogsians as well as Foxians. So thank you so much, and look forward to this webinar. And my best wishes to all of you. Thank you.
Now I request Rajendra Singh sir to tell few words about this webinar and about our and the best wishes for Sujit and Rashmi Kahar.
Good evening, everybody. Respected Chief Guest, Dr. Kiran Kurtukoti sir, Guest of Honors, Dr. Bharti Maheshwari, Dr. Kanchan Sharma, Amogs Secretary, Dr. Bipin Pandit, Conveners, Dr. Sujit Kondkar, Dr. Radha Lakshmi, Dr. Rashmi Kahar, and friends. I am feeling proud and honored to be a part of this program with AP societies. And in the tenure of and in the able leadership of Dr. Kiran Kurtukoti, Amogs has extended its academic partnership with AP societies. Not only AP societies, but even other UPCOG, TN societies also. And credit goes to Dr. Kiran Kurtukoti sir. So I wish to give credit to Dr. Sujit Kondkar also for this partnership, because now with his fetal medicine and even Amogs website committee also, now he has extended the partnership with societies. With the galaxy of speakers like Dr. Jagruti Murke, Dr. Manikandan, Chairperson, Dr. Sridevi Velanki, Dr. Ramarao, Dr. Narsingh Rao, Anurag Mai, I think this will be a great event. Dr. Sujit Kondkar is contesting for Fetal Medicine Imaging Science Committee Foxy chairmanship, and Dr. Rashmi Kahar, she is contesting for Practical Obstetric Committee chairmanship Foxy. So I wish every success to them for their future endeavor. Even Dr. Bharti Maheshwari is there, and now we need leaders like Dr. Bharti Maheshwari also in future for as a Vice President Foxy. So wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Now I request Sujit to introduce Bharti madam and also Kanchan Verma madam as guests of honor.
I'm very much glad to introduce our guests of honor today. Our respected Dr. Kanchan Sharma and Dr.
Disturbance. Sir, there are some disturbances. I will introduce, madam. it's a great honor and a great privilege to introduce respected Professor Dr. Bharti Maheshwari Madam to the House. As we all know, Madam is Professor and HOD, Department of OBGYN at Muzaffarnagar Medical College. And with diploma in IVF and reproductive medicine from Germany, we have seen her extensive work as chairperson of FOXI MTP Committee 2018 to 2020, with fellowship in medical education by MCI and a governing council member ICOG. We have seen and attended a lot of programs of conduct. She has been secretary of UPCOG and at present is president of Meerut OBGYN Society. And with this little introduction, I welcome you, madam, and we would like to hear from you. Bharti, madam, please unmute, madam.
Okay. Now am I audible?
Yes,
So, good evening, namaskar, thank you. And that is greetings from Uttar Pradesh, UPCOG. And it is really indeed a great pleasure to be a part of your webinar and that your publication and website committee, Amogs, with Amravati and Kunul Society. So really, it is a very great time for me. And Dr. Pardeshi sir, as we all know that he is a great teacher and is always inspire us to learn and to do good work for the women health, as well as Dr. Kiran Karkoti. He is the president nowadays, Amogs. He is also a very good friend of mine and past MTP committee chairperson. So really glad to be here. And as you are organizing this today's webinar on the aneuploidy screening in the first trimester and the second trimester, it is really a very important nowadays because I was being a MTP committee chairperson. I always emphasize that all abnormalities should be detected in time so that women can take decision if it has to be terminated as early as possible. And beside that, nowadays, because of elder age, because of ART procedures, because of environmental factors, lots of things that we have such late marriages, we have such issues, aneuploidies and others, and we have nowadays a very approachable and in fact affordable screening test as well as a diagnostic test of fetal medicine that is advancing and increasing and expanding their wings to even in the small places that we are in the periphery, we have all facilities to get it, but now the time or need is to get aware of all these, not only the doctors, even for the patient, because it is very difficult sometimes, even many times, to convince the patient that they have options for these tests like the 11 weeks or 13 weeks and they should go for them. So that is the issues, and we clinicians, we have to remain update about the not only screening, that how to interpret these things and how to carry forward. So we are very keen, I think, all of us to listen the coming lectures. And I'm also seeing my friend Dr. Kanchan and speakers as well as convener, co-convener. So congratulations to everyone and thank you for inviting me from UP. In your prestigious webinar. Thank you very much and best wishes.
Thank you so much, Bharti madam. And this is the second webinar of this maternal-fetal medicine series, and we are trying to conduct this series every Thursday at 5 to 7 p.m.
Good, very good thing, Rashmi, and I wish your practical obstetrical committee really best wishes. You are truly deserving person. I wish all the best to you. Yeah.
Thank you very much, ma'am. Thank you for your blessings. And it's again a very great privilege and a great honor to introduce Chairperson of FOXI's NCD Committee, Dr. Kanchan Sharma, Madam. Madam has been Secretary of Kanpur OBGYN Society since 2022 and 23 and President IHRF Kanpur. As we all know, with 33 years of experience, she is ART specialist, laparoscopist, and colposcopist. With ART and embryo handling training and also ultrasound and fetal medicine training from AIMS Delhi, she has been a recipient of FOXI Achiever Award, Pratigya Social Impact Award, Empowered Women Award, Nari Ratna Samman and Corona Warrior Award, Nari Suraksha and Nari Samman Award from the Police Commissionerate, and Kanpur Lifetime Achievement Award from Kanpur Society. She has organized many national and international conferences and has been organizer and chairperson at ultrasound workshops of UPCOG.
Thank you.
And most important thing is at this conference that it was attended by respected President of India.
Thank you.
So we welcome you, madam, and we would like to hear from you.
Thank you, Rashmi, for your nice words. Good evening, one and all. First of all, I want to express my heartfelt thanks for inviting me as a guest of honor. I am not a guest, but I feel myself one of the happiest person when I find myself in between you all in Amogs. I am always blessed and humbled by the graceful presence of respected Dr. Kiran Kurji sir, Dr. Vipin Pandit sir, Dr. Rajendra Pardesi sir. Always and always, I have a great family feeling with love and honor. My best wishes and full support to the conveners, Dr. Sujit and Dr. Rashmi, names already recommended by Dr. Rajendra sir and Dr. Kiran sir. His divine power has already granted you the knowledge and godliness for academic and the spiritual growth. You people will definitely succeed in your mission. My best wishes to both the speakers, Dr. Jagrati and Dr. Manikandan, and the esteemed chairpersons. Topics chosen are very good. Thanks for having me here and my best wishes to both of you. Thank you.
Thank you so much, respected ma'am, for all the love and blessings. Thank you very much. And I would like to now request Dr. Radhalakshmi madam to kindly proceed towards the first session of our scientific program.
Thank you, Rashmi. So I request Dr. Sridevi Velanki Madam and Dr. Ramarao to be the chairpersons of the first session. Sridevi Madam is a consultant at Sri Vijaya Maternity Hospital, Vijayawada, President Vijayawada Society 2024 and 25, Vice President 2023-24, and Secretary Works 2003 and 4, First Lady Honorary Secretary IMA Vijayawada, Vice President IMA Vijayawada, Organizing Joint Secretary of APCOG 2006, and Founder Secretary of APOGS after AP bifurcation, and she is the faculty at various CMEs and conferences. I request you chair the session, madam. Dr. Ramarao sir is actually belongs to our Kurnool. He did his UG and PG from Kurnool Medical College, Kurnool. Worked in AP government in various capacities. Worked in KIMS Medical College as professor at Amalapuram. NRI Medical College as HOD of OBG and Visakhapatnam. Retired from GEMS Medical College as HOD at Srikakulam. His areas of interest are cancer cervix, NDVH, and organizing issues. Sir is the president of Srikakulam OBGY Society. And I request you to chair the session, sir. And Rashmi, Sridevi Madam, I request Sridevi Madam to introduce Jagruti. Sridevi Madam.
Thank you, Dr. Radhalakshmi. Thank you for having me as chairperson in this wonderful session. Thank you very much, all the organizers. Now, Dr. Jagrut, the first topic is first trimester aneuploidy screening. What's new in that? What's new in that? By Dr. Jagruti Murthy. She's director and fetal medicine consultant, Daffodils Amravati, fellowship in fetal medicine, Mediscan Chennai. Over to you, Dr. Jagruti.
Thank you so much, ma'am. Can I get my presentation? Okay, before starting, I would
Yes,
like
ma'am.
to thank everyone. Special thanks to Kiran Kurtukoti sir, Rajendra Pardesi sir, Rashmi ma'am, and Sujit, and all the dignitaries here with Amba Devis and Ekvira, our Amravati goddess, their blessings. Let us start the topic. I will have to say next, right? Okay.
Yes.
Yes, ma'am.
So,
Yes, ma'am.
yeah, so we are talking about aneuploidy screening. What's new? Next. Okay, so prenatal screening, what is it? It's identification amongst the apparently normal pregnancies that are sufficiently at risk for specific disorders and justify subsequent invasive or costly prenatal testing. One second, I'm not able to see the slide. Okay, one second. Okay. Yeah. Justify subsequent invasive or costly. We need to justify whether we are doing invasive or costly prenatal diagnostic testing. There are animations, you will have to go as I read. Yeah, so the main objective is that our detection rate should be as high as 95% and a false positive rate of less than 1%. Next. So let us understand that every woman has a risk. Every woman has a risk that her fetus can have a chromosomal defect, and this background or a priori risk depends upon the maternal age and the gestation of the fetus. Next. So traditionally till now, maternal age, that is the advanced maternal age, was considered as a high risk for chromosomal defects, and invasive testing was done to all women aged more than 35 years. But this led to more than 20% of pregnant women undergoing invasive testing, and with a detection rate of only 30%. So now we know that age is absolutely an inferior screening tool. So because majority of these Down syndrome babies are seen in the woman having, in the younger age group. That I will explain in the further slides. So a discussion of various options available for prenatal diagnosis is now considered a standard of care for all pregnant women in the developed countries. So every pregnant lady coming to us should be told about all these aneuploidy screening that are available in the first trimester. Next. So this is the opportunity, the 12 weeks, the first trimester is an opportunity to not only screen but also accurately date the pregnancy. In case of twins, look for the chorionicities, do the NT, nasal bone, ductus, TR, do a detailed anomaly scan. Also screen for preeclampsia and FGR screening can be done. If needed, CVS can also be done in the first trimester itself, plus we can also screen for preterm births. So it's a need to invert the pyramid of care, and maximum care should be given at the first trimester, and then we triage the pregnancy accordingly. Next. So the most common chromosomal disorder is the Down syndrome that we are all doing this aneuploidy screening for, and it is the commonest single cause of learning disability. Next. So what do? We look for ultrasound markers. We do the biochemical serum biochemistry. Another options are non-invasive prenatal screening, and to diagnose, we need to do CVS and amniocentesis. Next. Okay. So aneuploidy screening, so we are covering first trimester, but what is all that is available to us? So the first trimester, we look for NT, nasal bone. We do the biochemistry where there is beta HCG and PAPE. Next. So the tests available for us are double marker, combined first trimester testing. So double marker is only a biochemistry. So the sensitivity is only 70%, while a combined first trimester test will include the nasal bone, the NT, the biochemistry, and the sensitivity is around 90 to 95%. Coming to second trimester, we have the quadruple marker, which is only 80 to 85%, and triple marker is only 70%. So definitely double marker and next please, double marker and triple marker next should be avoided and not done in future now. Next. So in the last decade, biochemical testing has moved to the first trimester screening, because when this is combined with the fetal NT, NB, the performance of screening is superior to the second trimester screening. Next. So the most effective method of first trimester screening is based on the combination of maternal age, maternal blood sample for beta HCG, as I said, next, an ultrasound scan done at, keep pressing, at 11 to 13 weeks, which will give us NT, nasal bone, fetal heart rate, tricuspid regurgitation, and ductus venosus. Next. So this is a study which gives again the same thing, and doing a screening at 11 to 13 weeks decreases the invasive rates at less than 3% and increases detection rate to almost 95%. Next. So this is something we need to understand when we read a report, because these trisomies pregnancies are associated with altered maternal serum concentration of various fetoplacental products. So if it is a Down syndrome, you will see that the beta HCG levels are on higher side and PAPE levels will be on a lower side. While trisomy 18 and 13 will show beta HCG at a lower side, next, lower, and PAPE will be also lower levels. So let us understand this. Most importantly is to understand the concept of multiples of median, which is MOM, and this method involves converting the measured concentration into multiples of median. Whatever we measure, we convert into MOM of the unaffected pregnancy of the same gestation. So when you get a report for a normal pregnancy, the average free beta HCG will always be 1 mom, and an average next please PAPE will be always 1 mom. So anything more than 1 or if is high, and less than 1 will be low. So and whenever you look at the report, please look at the moms, and if there are no mom values given, don't accept the report, because you cannot interpret it without it. Next. So to understand this, as you know, average in euploid fetus, average is 1 mom for both beta, sorry, both beta HCG and PAPE. So what happens in trisomies, we will see trisomy 21, as we had seen, the beta HCG is increased and PAPE, it is low. So as you can see in this slide, it has become 2 here, and here PAPE, it has become 0.5. Next. And also next. And 18 and 13, as you can see, they are low. Next, please. The values have gone down. So it is 0.2, 0.3 points. So always look at the moms. It will give you an idea what they are talking about, and whether there is really increased risk of these aneuploidies. Next. So what are the factors affecting first trimester biochemistry and risk prediction? So one is the maternal, in the mother is the maternal age, maternal weight, diabetes, a previous history of Downs, any injection, HCG given in the recent time, and smoking. In the fetus, we look at the number, the CRL, the nuchal translucency, the nasal bone, and the other markers. Placenta, we should look at the chorionicity, and we should also inform them whether it is in ART cycle, IVF, or a donor oocyte. So whenever, yeah, okay. So maternal age, one thing about the maternal age I wanted to emphasize here is the risk for trisomy will increase with maternal age. But it is very important to understand that there are a lot more pregnant women in the younger age group. So 70% of the fetuses with trisomies are in the women aged under 35 only. So screening more than 35 is anyways not going to give us more detection rate. So that is why better is to universally screen for all pregnant women, and that is how we can increase our detection rate. Next, please. A very good NT and nasal bone USG should also is very important, should be done by certified operators. Next, because NT depends on them. So a fetal NT in euploid fetuses increases with fetal CRL. So in trisomy also you can see as 80% of trisomy 21 fetuses, the NT thickness is above the 95th centile, the normal range. Next. So always accurate CRL measurement is very vital for the NT interpretation. So only NT is not of any use. There should be CRL, and only then you can say that this NT is raised or not. Next. Okay. So when will we not do prenatal biochemical screening? It is if at all there is any gross ultrasound anomalies on USG, gestational age less than 10 weeks and between 13 and 15 weeks. Then any known family history of single gene disorders, if there is a fresh ongoing vaginal bleeding, in case of vanishing twin, or if there is a fetal reduction done, then we cannot go and do a biochemical screening. Next. This is a newer thing that I wanted to share, that some labs are providing a dried blood spot to do a the combined screening the first trimester, where instead of the blood sample taken, the liquid serum that is being taken, the only a dried blood spot as shown in the picture is taken, and which is dried and sent attached to the requisition and sent. The advantage is that there is improved stability of the free beta HCG compared to the liquid serum during transportation to the laboratory, and also we reduce the biohazard risk. And patients are, I have seen that they are very compliant giving this type of blood sample rather than every time pricking them. Next. Okay, quadruple marker sir will take. So only thing is that again the sensitivity is less. So best is the first trimester. Next. First trimester screening. And next. This is in the second trimester, so I will not cover. Just mention about non-invasive prenatal testing, and now it's been widely used for almost all the patients wherever they are very, very curious. Even it is almost replacing the screening, the first trimester screening. So there are many studies that they have come up, and they say that non-invasive testings are good, prenatal testing are better tests. So let us see what they are exactly. Next. So NIPS, originally designed as a more accurate screening test for trisomy 21, 13 and 18, has now been available for several years. But one of the major advantages is that it has a strong positive predictive value as regards to trisomy 21. So it also has a superior detection rate to combine first trimester screening, so that over 99% of pregnancies affected by trisomy 21 can be identified. Next. Next, I'll go for the next, please. Yeah. So when would you do an NIPT? First thing is that whenever NIPT is decided to be done in any patient, an ultrasound has to be done, and it has to be confirmed that the baby is structurally normal. Okay, only then, in cases where there is advanced maternal age, maybe more than 38, which I follow, previous baby with pure trisomy 21. If baby is having translocations, then we cannot do it NIPT. High risk or intermediate risk in FTS or a quad test. And if the patient herself says that she wants a better screening test for her baby, she can be offered NIPT. Next. So what does it do? Let us understand what does it exactly do. Yeah, so cell-free, what it does it, the cell-free fetal DNA from the placenta. So in NIPT will look at the cell-free fetal DNA, which is coming not from the fetus, but it is coming from the placenta. This is first thing we need to understand. So we are not looking at the fetal DNA or a fetal karyotype. A lot of people think that this is a fetal karyotype, something just like a fetal karyotype, and whatever the report comes is that is the final answer. No, what NIPT does is, so what happens is the maternal blood contains fetal DNA as well as the maternal DNA. NIPT cannot separate the fetal DNA from the maternal DNA. NIPT just tries to assess the presentation of a particular chromosome after magnifying or amplifying the entire DNA from the maternal blood. Next. So what happens is the observed ratio of the material between these chromosomes is compared to the expected ratio, and if a greater amount of material than expected is found originating from a chromosome of interest, it is assumed to be fetal in origin, and a high risk or a positive call is made. So here the primary assumption is that the mother is normal and abnormal is coming from the fetus. Next. So you must have heard that there are a lot of false positives on NIPT. So this is the reason. In case of vanishing twin, the DNA from the vanishing twin can persist for at least 8 weeks after the demise of the twin. So again, it can be a false positive. In cases of maternal mosaicism, especially Turner syndrome, if the mother is a mosaicism, 10% mosaicism, then again it can give a gross report. Increased maternal age also have seen to be having a false positive report on NIPT, and any kind of maternal malignancy, you will see on the report there will be multiple anomalies, aneuploidies, that the fetus will be having. The report will be showing multiple aneuploidies in the fetus. Next. Another rare but still not, it's still possible is a confined placental mosaicism, because it is reporting considering placenta and fetus as the same thing. But whenever the placenta is different and fetus is having a different chromosomes, then this doesn't apply. Then we can go wrong. Next. So coming to the limitations, 3 to 5% of times, again, there can be no results also or no call. Then this happens because of the low fetal fraction or assay failure and a sampling and a transport error. Again, high cost is another thing. It fails to detect other aneuploidy. It is only good for trisomy 13, 18 and 21. And once, if at all it is positive, we need to confirm. If at all any report comes high risk, we need to confirm it by amniocentesis for confirmation. Next. So why low fetal fraction? Low fetal fraction usually comes with if the gestational age is less than 10 weeks, if there is a suboptimal sample collection. In cases of maternal obesity, fetal aneuploidies, in real fetal aneuploidies, and if there is a poor placental function like trisomy 18, and you can get a low fetal fraction, and then we will land up with no report or no call. So if the fetal fraction is less than 4%, the sensitivity goes down to almost less than 70%. Next. So the high sensitivity and specificity of NIPS has incorrectly led some providers to believe that they are diagnostic tests, but this is not a correct assumption. One important reason for this is that the cell-free DNA analyzed by NIPS originates from the placenta, predominantly the cytotrophoblast. So it is not a fetal origin. Next. So so the thing we need to remember is the positive result on NIPT does not mean termination. We need to confirm. This by amniocentesis. Next. So, can NIPT replace the first trimester? The answer is definitely no, because first trimester screening, if you say, it includes the NT scan and the blood test. So whenever you do a NT scan, we get a lot of information, and we can confirm the presence of a live fetus, exclude twins or higher gestation, and may identify major structural anomalies like anencephaly, and also definitely will measure nuchal translucency. And NIPT is focused only on screening for chromosomal abnormalities, so it cannot replace the other aspect of first trimester screening. Next. So, to evaluate non-chromosomal aspects, NIPT should be integrated into a program which includes ultrasound and a spina bifida detection. Next. So how far should the testing go? Now, this is just a slide which I thought I will just include because we want to know what's new. There are NIPTs who are, in addition to assessing the likelihood of presence of whole chromosomal aneuploidies, a number of tests claim to be able to detect broad range of microscopic and submicroscopic deletions and duplications, but we are still to go to that point where we are very sure that we get at least to a better detection rate for in such cases, and reduce the false positive rate, because these are rare conditions, and rarer the condition, false positive rate increases in the NIPT. Next, please. Next. Next. So the accuracy of NIPT depends on the precise technology and the fetal fraction. NIPT has not been sufficiently validated in women at low risk for fetal aneuploidy till now, and NIPT cannot replace CVS and amniocentesis. Those are the confirmatory tests. So I've just made a checklist for everyone us to remember every time we do a first trimester screening, that we are doing it at the CRL of 45 to 84, which is 11 to 13 plus 0.6 weeks. NT scan should be done by a trained operator. Always check CRL. Even the obstetrician should have a habit of looking into the CRL. What is it taken? Whether it is how the CRL is it very curved or extended? Whether it is taken right. Ensure the dates are correct whenever the screening is done, because it depends upon what is the date. Dating is very important. Look at every NT image in the report, even if it is they have given raised we can also look into the NT and really it is raised or whether taken properly or not. Look at the biochemistry, look at the norms, whether it is given, and without norms, do not accept the report. Next, please. Check if the risk prediction has included sometimes here also problem happens, whether the risk which is given, whether it is including the NT, nasal bone, biochemistry, and the combined risk has been calculated in the appropriate software. The report should mention both the age-related risk and the final estimated risk. Also, in case of low PAPE, this is one more condition. Down syndrome, there is low PAPE, but again, one more condition. If the report is normal, the final risk is normal, but there is still a low PAPE, these babies are prone for IUGR. And the mother can develop PIH. Also look into the uterine artery Doppler if it is done. And you can start her on aspirin prophylaxis. So this is one thing that you need to see, look at the mom. Next. So in case of IVF, donor age should be used to calculate the risk. In case of twins, only first trimester screening should be done. Please do not do quadruple screening. And chorionicity should be properly mentioned. In case of higher order gestation, calculate only NT-based risk. No screening can be done. Next. So this is the requisition form, which is which should have all the information, the birth date, the LMP, the date of scan, and this is all the measurements. Well, this is the history, because when we send it to the lab, again the lab keeps asking is what the details. So it is better that we only provide them proper information and we get the report on time, and the patient also is never confused then. Yeah, I think that's the last slide. Thank you. Thank you so much.
Yes, Dr. Jagrati, that was a very extensive presentation. Very well done. Congratulations.
Thank you so much.
And you have enlightened us on so many aspects regarding first trimester screening. But wouldn't you agree that in 90 scan, we have to routinely do uterine artery Doppler also, so that we can predict.
Yes.
In addition to prediction of aneuploids, predict PIH and FGR, isn't it?
Yes.
And what about that spot test or paper test, doctor? How far is it sensitive or specific?
It is the same as we do is. I will have to look into it, but this is, I just found out what all new you can have in this scenario. So then, this is something new I thought I should mention in this, because I'm talking about what's new. So so this is also something we can offer to the patient, but I think this was from the PerkinElmer, and they are doing it, and so in fact Mediscan, when I was in Mediscan, they were using it, and sir, I think they still use it there. So
very nice. Thank you.
They have equal the sensitivity, specificity is good only, no issues.
And one more thing, do you recommend if she goes for amniocensus, do you recommend a targeted aneuploidy screening or generalized, like all the chromosome array, or targeted chromosomal array?
No, it depends upon what we are going to. It's only if it's
what we are looking at.
If she is having any structural anomalies, then according to that. But it is only because of the high risk FTS. Then I am more worried only about Down syndrome. So a karyotype is enough.
Okay,
but if there are these structural anomalies, then I would nowadays prefer to do a microarray rather than doing a karyotype.
Okay. Thank you.
Thank you.
Would Dr. Ramarao Garu add anything to this? Dr. Ramarao, sir?
Ramarao, sir. Please tell your expert opinion, Ramarao, sir. So, please unmute yourself, sir. Ramarao, sir.
Some disturbance.
It is well covered, madam. Very nice talk you have given. But the thing is, India is a poor country, and it cannot afford for a general screening. Otherwise, all the technology is towards the people who are having more money, affordable people, where the society, government, or other agencies should come and rescue, see that the cost of this test should be less, so that it will be available for more people. That is my advice and request for all of us. And some people
True, sir, true.
invariably writing
Definitely.
all the tests, whether they can afford it or not. So that we have to use our discretion. Then only we can save the purse of the patient and their payment. Okay, with that.
Would you like to take opinion from Dr. Sujit sir also? He is the very senior telemedicine specialist with us today.
Yeah. What Rao sir said is quite true. India is poor country. But now, if you look at the health status and health problems of our country and rising rates, rising incidence of all these things, patient have to spend something on that. At least ultrasonography, look at sonographic features, not spend much more on let alone blood investigations and all those things. But Jagrati's talk was very nice. She has covered very some new things, very good things about new things about NIPT also.
If at all, I would like to, if at all the patient is poor and we cannot do the screening, I still think a good, properly done NT scan will suffice. You know, NT-NB, we can give the NT-NB risk. We can combine that and give, and at the same time, even a uterine artery Dopplers can be done. So a lot of things can be covered, even if they don't want to do screening.
Detection rate is
But
almost
NT
90, more
scan
than
is
90%.
important.
Detection rate is more than 90% with that only.
Yeah, that's the thing. So here we can cut down the screening biochemistry part, but then NT, it cannot replace, still not replace not doing an NT scan, I guess.
Yeah, I would request Dr. Malikandan to say something about this.
Yeah.
Okay. We are talking about a condition that is quite rare in prevalence, so may not interest public health policy stakeholders, but has a deep impact on the emotional, financial, and social status of an affected couple. So it's best left to them after a good discussion and not impose our idea of what constitutes their wallet heaviness. So I'm not antagonizing what was said by Professor Ramarao, but it's best left to the patient to decide whether they can afford it or not. As much as we have to protect them, we also have to protect ourselves.
Right.
I have one case. Can I talk?
Yes,
Yeah,
ma'am. Yes, please.
Recently, we have had a case here, like another obstetrician. That patient underwent anti-scan, TIFA scan, quadruple screening, then growth scan. Finally, 9th month she delivered, and the baby had spina bifida. So, so the doctor was sued. It went the judge that read the report as quadruple the screen, we get it as low risk. Low risk for us means we take it as normal. So saying that, the judge said, since it's given low risk, why wasn't the couple warned that it can be an anomalous baby? So now 50,000 compensation that husband is demanding. 50,000 from the operation and 50,000 from what happened that poor and they cannot afford, and like maybe this patient underwent everything. Growth scan we usually don't look for. I mean, there's a line also written there. There's a sentence, isn't it? All anomalies cannot be detected because of the size of the fetus in growth scan. Maybe spina bifida could have been detected at the time of growth scan, but then this is what happened.
It's
What
best
are
to
your
place
comments?
our interests first, know the limitation of the practice that we undergo. The science is limited. It's not a perfect science yet. Even obstetrics for that matter. We have been practicing modern obstetrics for close to 200 years, and yet we still have complications which patients don't understand as complications, and sue us as negligence. This is an evolving science, so it's best to and the landscape of practice patient-doctor relation has vastly changed from the time I was a student to now I am being a practitioner. The change is dramatic. We need to adapt to the change, and as much as we work as a group in safeguarding our interests in practice, also we should involve patient and share the responsibility of every decision. So that's my opinion on that. I fully agree with Dr. Sridevi's anecdotal. It's very difficult to tell if I think the compensation was less purely because everything was done. In spite of that, it was less. Otherwise, they would have sued for lakhs.
Yes. 50,000 is less, madam.
50 lakhs.
50
okay.
lakhs.
No,
Yeah.
did I say 50,000? 50
Yeah.
lakhs.
50 lakhs.
50 lakhs each. Obstetrician and sonologist.
Yeah.
50 lakhs each, not 50,000. Did I say 50,000? It's
Yeah.
50 lakhs. And actually, the judge should ask for an expert opinion. This is what happens when judiciary doesn't know medical terms, isn't it? No, I feel that such cases should go to a medical judge, at least one who has done, isn't it?
Right.
But opinion will be sought, of course.
Actually, they should before giving such before giving such huge compensation, the judge should ask for a medical board opinion.
Medical board. Case must be referred to a medical board, madam.
Yes,
Of medical specialist. I had one baby. That TIFA scan was done. The patient delivered the female child having syndactyly, affecting only 3 fingers of left hand, and he came to my clinic and started arguing. So you made us to undergo TIFA scan, but they failed to recognize that syndactyly. I asked him whether you go for termination if only the syndactyly is the reason for you to quarrel with the doctor. Then he went away. So I took the help of some police people at that time because he created some scene in my clinic. He doesn't went to any court at that time. So only problem that baby having was syndactyly. So now I request Sujit sir to introduce our the chairpersons Anuraga Mai madam and Vayalan Rao sir.
Yeah, I'm very much glad to introduce our chairpersons. Our next chairperson is Dr. Y.L. Rao sir. He is President of Obstetrics and Gynecological Society of Visakhapatnam 2024-2005. Was Secretary of Obstetrics and Gynecological Societies of Visakhapatnam 1997-1999. As former professor and head of Department of Obstetrics and Gynecology, Andhra Medical College, King George Hospital, Visakhapatnam. And he has vast teaching experience of more than 26 years. Our next chairperson is respected Dr. Anuragmi Yelamachi, ma'am. He is professor and HOD Ubijoy Rangaraya Medical College, Kakinada, President Kakinada Obstetrics and Gynecological Society. She has published articles in index journals and presented 3 papers in state and national conferences. And she has participated as faculty in various state conferences and UOFOXY. Yeah, so I request Violin sir to introduce Dr. Manikanda, our next speaker.
Thank you, sir. Sujit, all the best to you, Sujit, for the Emerging Science Committee chairperson. And I'm happy to introduce Dr. K. Manikandan. He had postdoctoral fellowship in fetal medicine from Mediscan Systems, Chennai. He's all this is famous. And former associate professor of OBG in Jepmar. And research fellow in fetal medicine, King's College Hospital, UK. And special training under National Teacher Training Course for Teachers of Higher Education in Jepmar. From all the primary institutes, he got the training. And statistics and epidemiology training from Harvard, quantitative methods in clinical and public health. I'm sure he will enlighten us so much in the second trimester's genetic sonogram. So not only anomalies, structural anomalies, but for these markers to know about the suggesting aneuploidies, etc. I request Dr. Manikandan to deliver the lecture and enlighten us. Thank you.
Thank you, everyone, and thank you for this wonderful opportunity. Dr. Narsingh Rao, thank you for the kind words of introduction. Let me start by sharing the screen. I hope this is visible. Please let me know.
Yes, sir.
Right. All right. So when we talk about genetic sonogram and soft markers in ultrasound, we are typically talking about the second trimester scan, starting in about 16 weeks to 24 weeks. The first trimester markers are not included in the general sense when we talk about the genetic sonogram. We will see this concept with a series of question answers so that our gray areas, gray zones are clarified. When we say soft markers, which condition do we mark with soft markers? Of the several conditions shown here, which all of them are genetic, this is Down syndrome, this is Edwards syndrome, this is Patau syndrome, this is Turner syndrome. We are marking Down syndrome. When we say without qualification, when we say soft markers, we mean markers for Down syndrome. So why are we behind Down syndrome and not others, which we also see in practice? This is because all pregnancies are at risk for Down syndrome, need not be advanced maternal age, need not have family history, need not be consanguinity. And though we know advanced maternal age is associated with higher chance for Down syndrome babies, because younger women are far more numerous, of all the babies, Down syndrome babies that are born, more than 2/3, 70% are born to quote unquote younger women, women of lesser than 35 years of age. Though Down syndrome is a serious genetic disease, has profound mental, intellectual disability, not mental, it is asymptomatic in about 50% of the fetuses, in the sense that the fetuses do not show any ultrasound defect, contrary to the other common trisomies, that is Edwards syndrome and Patau syndrome, where a trained fetologist, a fetal sonologist, will be able to pick up the vast majority. In Down syndrome, this is going to be an normal looking fetus. And again, in contradistinction to other genetic syndromes, that is other autosomal trisomies like Patau and Edward, in utero lethality for Down syndrome is low. That is, only about 20 to 30% of fetuses which have Down syndrome will ever die in utero, and rest are going to be born. So these are the reasons why at the beginning, when an opportunity for a prenatal diagnosis came up, Down syndrome came on the forefront of screening. The screening itself is complex and requires a lot of thinking from our perspective. For example, the very information that Professor Ramarao told, we are low resource setting, so whether we will be able to do it in a justified manner. I have discussed all these things in my paper, Down syndrome screening, are we there yet? It's a free article available from our National Foxy Journal. If you have time, look at it. Now, before we understand genetic sonogram, we must understand a very important terminology when it comes to Down syndrome screening. and that is called a priori risk, or the chance before we begin a test. Now, a priori risk in Down syndrome, that is, every pregnancy carries a chance that it is going to be a Down syndrome, and this chance increases with maternal age. We have authentic Indian data. This was published as part of my paper, but this was from great Dr. I.C. Verma, his paper. We can see that the chance increases as the maternal age increases. That is, when the mother's age is 18, the chance of the fetus having Down syndrome is 1 out of 1,500. So you need to have 1,500 pregnancies of younger 18-year-old mothers to encounter one Down syndrome. Whereas if you go to 39-year-old, 42-year-old, which are becoming common nowadays thanks to IVF technologies advancement, you see that for every 100 or even lesser pregnancies, you will encounter a Down syndrome fetus. So the a priori risk for Down syndrome is the maternal age, and all calculations for Down syndrome, that is chance calculation, probability calculation, starts with the maternal age. So before again, we need to clarify what do we mean by soft marker. There are two words to this phrase, soft and marker. So I have shown you here three pictures. This is a single umbilical artery. This is an increased nuchal fold thickness, and this is a talipes, deformity of the foot. If we see umbilical artery, single umbilical artery is not a soft marker. Talipes is not a soft marker for Down syndrome, whereas increased nuchal fold is a soft marker for Down syndrome. So, why is this? When we say soft, that means it is not a defect that would end up with a handicap. So, talipes is not a soft marker. It's a hard defect. It will end up in a handicap. This will require not screening, but an invasive diagnostic test. And as Jagrudi alluded to, this will end up with an amniocentesis, a chromosomal microarray. Usually it will be normal. In rare cases, you will find something, and then the postnatal management. The single umbilical artery is not a soft marker for Down syndrome because it is not seen more frequently in fetuses with Down syndrome than in fetuses with normal chromosomes. So therefore, because it's not seen more frequently, it's not a soft marker. Whereas in this case, that is, an increased nuchal fold is a soft marker. It does not cause handicap, and yet it's seen more frequently in fetuses with Down syndrome than in normal fetuses. Therefore, it can be used as a marker, and it is a soft marker. What is the purpose of soft marker at all? Why did it come into practice? Before, we now have pregnant population, we apply a screening test. The women is either screen positive, then undergoes a diagnostic test, that is an amniocentesis, or she is screen negative, and then we say, okay, routine follow-up. But before the screening test came into view, women were offered amniocentesis based only on their age. So if you are 35 and above, you were offered amniocentesis routinely. And they understood that a vast majority of them would be still normal babies, even to those who were more than 35 years. So these markers came to categorize women who were already being offered amniocentesis to see if they had any marker, then they would be offered. If they didn't have marker, then it was optional. They could pull out of the amniocentesis program. So this was sort of a screening that was done before the serum screening, the triple test came into vogue. And just to follow it up, triple test is obsolete. It was replaced by the quadruple test, which was then replaced by the combined screening test. So before all these tests came, genetic sonogram was introduced. So the natural follow-up question is that in today's practice, which states that the standard screening should be a combined screening test, as Jagruti told, at least an NT-NB screening, or for late bookers, a quadruple screening test. Do soft markers have any clinical relevance? They do have, provided we understand the rules of the game. And the first rule is we should know all of the soft markers and we should assess all of them together. And when you assess all the ultrasound soft markers and report them, it is then called as the genetic sonogram. The clinically relevant soft markers in today's practice are, a few have come and gone, but the ones that have stood the test of time, firstly from head to toe, firstly, as you can see here, mild bilateral ventriculomegaly. If it's severe, if it's unilateral, it doesn't account to being a soft marker. Then increased nuchal fold thickness, unossified or absent nasal bone, aberrant origin of the right subclavian artery. You can see here, this is the back of the baby. We are showing the most posterior most section. The blue large one that is coming from left to right, right to left, is the descending aorta. And you can see that the right subclavian artery takes origin from the descending aorta. That's an aberrant origin. Here is a 4-chamber view of the heart. In the left ventricle, you can see a shining bright dot, which represents calcification of the papillary muscle. And this is also considered a soft marker. This is a coronal section of the fetal abdomen. All that you are seeing is this bright spots is the fetal bowel wall, and by the side there is a comparative iliac bone. When this bowel is as echogenic as the bone, then we call it as an echogenic bowel, which is the next soft marker. This is an axial view of the fetal abdomen with the spine up. You can see that the two kidneys show mild pelvic dilatation. Mild pelvic dilatation is when the anteroposterior diameter is more than 4 millimeters but less than 7 millimeters at the mid-trimester. So when it is bilateral and mild, it constitutes a soft marker. And these are images of the proximal long bones, humerus and femur. And when they are relatively short, less than the 5th centile but not less than the 1st centile, then they constitute as soft markers. So all these 9 soft markers should be assessed together in a fetus, then they are clinically relevant. So we give a card like this. This is the soft marker card. What do we do if the soft marker is present? Do we immediately say that the baby has a problem? No, we don't. We don't say that the baby has Down syndrome. And to understand how we are going to use the soft marker in the management or in the screening for Down syndrome, I will introduce you a new term called likelihood ratio. It is not a big statistical term that we should be afraid of. It's just that by what factor the condition is more likely if we find a problem, if we find a symptom. It's very common in clinical practice to use this intuitively. We don't use the term, but we use it very intuitively. For example, a lady comes with a lot of pelvic pain and she has been having long infertility problem. Then there is a possibility that it could be any cause of pelvic pain. But we do a test, say for example, a bimanual examination, and we find that the uterus is fixed, there is pelvic tenderness. So our likelihood of diagnosing an endometriosis is more. We know that in our mind, we just simply don't put it across as number. When it comes to Down syndrome, because it has been studied over so many years and a lot of statistical science has been applied, the likelihood ratio has propped up. This means that when you see a marker, say for example, the increased nuchal fold thickness, among fetuses with Down syndrome, it's seen in 60% or 40%, whereas among normal fetuses, it's seen in 1%. So in Down syndrome fetuses, its prevalence is very high. In normal fetuses, its prevalence is low. So you divide the prevalence in Down syndrome divided by the prevalence in normal. That ratio is called the likelihood ratio. In the example that I have provided here, this talks about absent nasal bone and the likelihood ratio is 50 times. That means 50 times it's more in Down syndrome fetuses. I have discussed these concepts at length in another publication. I have put it here. For those who are interested, can go through this. I have simplified it with examples from our own practice. All right. So once we know the soft marker, and for each soft marker, we know the likelihood ratio, then it's a matter of probability calculation. We have already, through studies, understood what is the likelihood ratio for each and every marker. I request you to omit column red and blue and focus on the gray column at the end here. Say, for example, if there is an absent nasal bone or unossified nasal bone, the likelihood ratio is 6.5. That means the fetus is 6.5 times more likely to have Down syndrome. So automatically it means that we should know what was the initial probability. And as I said before, the initial probability or the a priori depends on the maternal age. But also, if somebody has undergone a first trimester screening, then that result will be the starting point for the likelihood ratio application. So, for example, I will explain it at the end also. If you see item number 1, 2, 3, and 4, they have high likelihood ratio when they are present even as isolated finding, but the rest will have low likelihood ratio. So, these are called as the high risk soft markers. So when they are present even as a single soft marker, we need to look into the overall situation carefully. Whereas these other soft markers, when they are present isolated, when they are present as a single soft marker, we need not be very much bothered. Having said that, there are certain pitfalls we should be aware while doing a genetic sonogram. What are the pitfalls? Each and every soft marker that I had mentioned is subject to misinterpretation, misdiagnosis, false positive, and false negative. Therefore, it requires adequate training and audit, skills, knowledge to perform a genetic sonogram. Should not be taken lightly. Say, for example, here, these are two images of the same babies. What appears like very echogenic bowel, when you turn off certain enhancing presets in the machine, it becomes an okay bowel. The similar applications, similar considerations apply for the nuchal fold thickness. You need to be in the right plane. If you over tilt, then you will measure too much. Again, you need to be in the right plane for the nasal bone. If the baby overextends, then also you will make a false diagnosis of hypoplasia. So on and so forth. So what is contingent screening? This is another concept that has come recently. I will just touch upon this. I had mentioned that there is a classical screening where you screen. It's either screen positive or screen negative. But some people have, and some practitioners have started doing this. That is, after screening, the results are classified into very high risk, which directly goes for diagnostic test, very low risk, which you can then routinely follow up with clinical. And then there is an intermediate risk, which will then require a next level of screening to put it either into high risk or low risk. So, coming back to the rules of the game, should we report soft markers at all? You should report, but only if you report all of them and as part of a genetic sonogram. The gestational age is very important. You should report it between 16 and 23 weeks, not before, not after. It really doesn't matter before and after because the likelihood ratio is unknown. Some people have extended it up to 14 weeks, okay, but not in the first trimester. You should assess all the 9 soft markers and then use the ones which have positive likelihood ratio for those soft markers which are present, and also for those soft markers which are absent, use the negative likelihood ratio. For example, there is an unossified nasal bone. Simply don't write unossified nasal bone and then say that the fetus is at risk. Check for all others. If unossified nasal bone increases the risk, absence of other soft markers will simultaneously decrease the risk. So everything should be documented. And also one should be technically competent to overcome, identify, and avoid the pitfalls. So how do we actually use the genetic sonogram in clinical practice? So I'm going to show you a short clip. This is from the software called SonoCare. So once you complete the genetic sonogram, say for example here there is an unossified nasal bone and then there is a increased nuchal fold thickness, we open this page called risk calculation. So here the maternal age, which is the starting point for all risk calculation in Down syndrome, is entered. So it will say that the starting risk is 1 out of 1,300. And then we assess all of the 9 soft markers. The only thing we have to know that when humerus or femur is short, only one should be taken because they are, they show collinearity. So let me start so you can follow the arrow inside. So tick the increased nuchal fold and then go and tick the absent. So the software understands that these 2 are present and all the rest are absent. Now, if she had undergone a previous screening, then you enter the first trimester value in this box. So what we are doing is, if she has undergone a first trimester screening and she has a value, that value becomes the a priori risk for calculation. So we cannot ignore that, we have to put it. But if she has not undergone the screening, then we go here and click it. Then the software will take the age as the background risk and then it will give. You can see the difference. When we take the age as the risk and put these 2 markers are present, rest are absent, the chance is 1 in a 9. Whereas when you enter a prior risk, for example, in this case, a 1 in a 10,000, then the chance becomes 1 in 70. So the chance changes based on what was the previous risk. So it's important that we understand the previous risk based on any other test that she has done. Now, this is another example. This is another situation. This is a usual practical scenario. So she is a 30-year-old going to become 31, and then she has undergone a quadruple screening test, and that has returned 1 in a 268 as the report. Now we are okay to call it low risk, but if you want further reassurance, you can perform a genetic sonogram and then see if anything is present or not. Then enter the background risk as 1 in 268 and then see if anything is there, you put across. Otherwise, if none of them are there, then leave everything blank and then go and calculate the post genetic sonogram risk. Now it has come as 1 in 893. We can very well reassure the patient. So in this way, for borderline calculations, borderline risk that comes out of serum screening, you can use genetic sonogram to modify, fine tune, and provide further reassurance, or to provide further conviction that we need to take an invasive step. Therefore, in summary, the genetic sonogram has a role in today's practice, especially because, as the previous speaker told, NIPT is still a we are still very much far away from getting NIPT for everybody because of the cost issue. So we do see cases where the combined screening test or the serum test will come in a borderline value, in which case we can use the genetic sonogram to further modify the risk calculation and put them into either high risk or low risk. So we can use it as a contingent screening. Contingent means what if there is a borderline screening, then we bring in and do it. It has to follow the rules. We need to do everything. You need to know how to overcome the pitfalls. And also, we need to know that the baby does not have any hard defects. Remember, genetic sonogram is only valid when the baby is otherwise asymptomatic, that is, appears normal structurally. Thank you very much. I am open for questions.
Any questions, sir? Welcome. Thank you, Manikan, for elaborate and new aspects. So we have to be very careful because we have to search for all these things, and probably a routine gynecologist may not be able to tell. You have to depend on the expert fetal medicine specialist. And I have a doubt, when you have these soft markers, should we recommend them NIPT or go for amniocentesis, which is better, or what do you suggest?
Yes, sir. Thank you. Thank you for the question. So I had specifically left out the specifics of the management. In general, when we have a good first trimester screening, let's say a very good NT image is available and a reliable lab has done the biochemistry, and therefore the first trimester screening has come back as low risk. And then incidentally, we find a soft marker during the second trimester scan. We can simply recalculate the risks as I had shown you, and then decide whether we need to take an action at all or not. So in the example I shown, two heavy soft markers, that is nuchal fold and nasal bone, where they were able to modify the risk from 1 in 10,000 to 1 in 90. In that case, usually we will go for an invasive test. Now, suppose a good first trimester screening is done, but you have only one soft marker that is not usually counted as a defect. For example, unossified nasal bone. It's very specific to nasal Down syndrome. It doesn't have any other association. So there, NIPT is also an option. So it depends on the case-to-case basis.
Earlier, some echogenic fog in the left ventricle, we need to assure the patient that many times it will not have harm. Or should we do in such?
Absolutely correct. Any of the lesser soft markers that I have shown, there is no need to even escalate if you see a single isolated dot in the left ventricle, provided that you know that the reporting person, whether it's a sonologist or a radiologist or even a gynecologist, can also do a good quality ultrasound as a first line. And if you're sure that you don't have any other soft markers, there is no need to escalate all those minor ones.
Thank you.
I request Anuraga madam to give your expert opinion. Please unmute, madam.
Good morning, good evening all. Thank you very much, sir. Sir, Manikandan sir, it's an excellent talk, sir. Very interesting. Thank you very much.
Okay.
So well done, Radhalakshmi madam, and we wish all the best to Sujit Konkar in the coming elections.
Oh, yeah. Best
Nice to
wishes, Dr. Sujit. Full support.
Thank you, YLN Rao sir, Anuraga Mai madam, and Sridevi Velanki madam, Rama Rao sir for accepting as the chairpersons to this webinar. And I wish all the best to Sujit sir and also Rashmi Kahar. Wish you all the best in your future elections.
Yes. All the best to Rashmi Kahar
I
madam
request
also.
all of you to vote for Sujit and Rashmi Kahar.
Okay, sure.
It's a great honor for me to propose a vote of thanks to all of you. I'm extremely thankful to President Amogs, Dr. Kiran Kurtakoti sir, to allow us to conduct this webinar, and guests of honor, Dr. Bharti Maheshwari madam and Dr. Kanchan Sharma madam for their esteemed presence. To the special guests, Dr. Bipin Pandit and Dr. Rajendra Singh Pardeshi, we are thankful to both of them. And special thanks to the conveners, both the conveners of this webinar, Dr. Sujit Konkar sir and Dr. Radhalakshmi madam, for crafting such a beautiful and highly academic scientific session for us. Thanks to esteemed scientific faculties, chairpersons, respected Dr. Sridevi Velanki madam, Dr. Rama Rao sir, Dr. Y.N. Narsingh Rao sir, and Dr. Anurag Mai madam. And last but not the least are both the speakers, Dr. Jagruti Murke and Dr. Manikandan sir. Thank you for your wonderful presentations. Thank you so much, Shield Healthcare, for your educational support, and to all the viewers of this webinar. We'd like to inform on this platform that every Thursday, we will be carrying this series with various topics, and we would like to request you to kindly join us on each Thursday, 5 to 7 p.m. for this series. Thank you very much.
Thank you.
Thanks all. Bye.
Thanks. Thank you.
Thank you so much and have a nice time.
Thank you. Thank you so much, ma'am.